Welcome to our video on pneumothorax. Let's get started. Here's our overview slide. Let's begin with the definition. Pneumothorax refers to air within the pleural space. There are three general types: spontaneous pneumothorax, that can be primary or secondary, traumatic pneumothorax, and tension pneumothorax. Now let's discuss the pathophysiology. The air in the pleural space leads to the loss of negative intrapleural pressure, which leads to pulmonary collapse. Okay, with this in mind, let's discuss spontaneous pneumothorax first. Spontaneous pneumothorax can be primary or secondary. Primary spontaneous pneumothorax, also called simple pneumothorax, occurs in healthy individuals and is not associated with underlying disease. It mostly affects tall young men. Usually it's not a life-threatening condition and often resolves on its own. Secondary spontaneous pneumothorax occurs due to an underlying disease, like COPD, cancer, or TB. It's more life-threatening than the primary one. Traumatic pneumothorax, just like the name suggests, is caused by trauma. It can be iatrogenic and occur, for example, during chest tube insertions. It could also occur due to mechanical ventilation, specifically PEEP. Penetrating and blunt trauma can also cause traumatic pneumothorax. It can be open or closed, and we'll discuss the differences between these two shortly. Here's an image from our partnership with Amboss, which highlights several important features of pneumothorax. In this image, you can see that there is spontaneous pneumothorax and pneumothorax. So on the left side, spontaneous pneumothorax is divided into primary and secondary, and on the right side, pneumothorax is divided into traumatic and iatrogenic. Primary spontaneous pneumothorax occurs due to rupture of subpleural blebs, causing air to reach the pleural space, so the air enters the lungs. In secondary spontaneous pneumothorax, an underlying lung disease causes entry of air into the pleural cavity from the lungs. So, secondary pneumothorax is usually caused by underlying lung pathology. Trauma leading to an open pneumothorax introduces air into the pleural space from the outside. And in iatrogenic pneumothorax, puncturing the lungs during procedures introduces air into the pleural cavity. As you mentioned before, traumatic pneumothorax can be open or closed. In open pneumothorax, you can see that external trauma introduces air into the pleural cavity, which can cause lung collapse. It's considered closed during blunt trauma, for example, when air enters the pleural space but no communication between the pleural cavity and the outside is present. In closed pneumothorax, air enters the pleural cavity from the lungs, and no connection is established between the pleural cavity and the outside. All right, now let's discuss tension pneumothorax. This is a condition where air enters the pleural space but cannot go out. If left untreated, continuous air entry will lead to increased buildup of pressure that can eventually push on the contralateral lung as well as the heart and other major structures. This can be very dangerous as it can impede the venous return and cardiac output of the heart. Therefore, it's a life-threatening condition that can lead to hemodynamic instability and collapse. Risk factors for tension pneumothorax include mechanical ventilation, such as PEEP and positive pressure ventilation. These are common mechanisms that can cause tension pneumothorax and should be kept in mind when a patient is on mechanical ventilation and suddenly starts to decompensate. Other risk factors include trauma and CPR. In this image, notice that it's depicting the mechanism of tension pneumothorax. Tension pneumothorax occurs due to a structural disruption of the parietal or visceral pleura that leads to the formation of a valve which allows air entry but does not allow the air to exit. This leads to positive intrapleural pressure and ipsilateral lung collapse. On the left side of the image, we can see air entry into the pleural cavity upon inspiration when the valve is open. On the right side of the image, we can see how the air cannot escape from the pleural cavity when the valve is closed, which leads to the expansion of the pleural space and increased positive intrapleural pressure. All right, now that we've discussed the specific types of pneumothorax, let's discuss the clinical presentation in general. Patients with pneumothorax present with acute and severe pleuritic chest pain that is mostly unilateral. Dyspnea is also usually present. Patients with tension pneumothorax can present with hemodynamic instability with hypotension, respiratory distress, and hypoxia. History and physical exam can be very suggestive, and patients present with decreased or absent breath sounds, hyperresonance upon percussion, and decreased tactile fremitus. Distended neck veins or jugular venous distension can also be present in significant pneumothorax. This is because the increased intrathoracic pressure interferes with blood entry into the heart. As a result, the blood backs up into the superior and inferior vena cava, and distended neck veins are seen. Subcutaneous emphysema can also be present in patients with open pneumothorax. On imaging, a chest x-ray confirms the diagnosis and shows decreased lung markings and lucency changes. Findings supportive of tension pneumothorax include tracheal and mediastinal deviation towards the normal side and ipsilateral diaphragmatic flattening. An ultrasound is especially helpful in the setting of trauma and is part of the FAST protocol. Finally, a CT scan can also be used. Here is a chest x-ray of a patient with a left-sided pneumothorax. Notice the well-delineated area with absent lung markings, for example right here. There's also clearly tracheal deviation as well as heart deviation to the right, which suggests a tension pneumothorax as well. Here's another chest x-ray of a patient with pneumothorax. Here, notice the change in lung lucency on the right, and this is the collapsed right lung. Here is a chest CT of a patient with left-sided pneumothorax. Notice the area of increased lucency highlighted by the black arrow. The general management of pneumothorax starts with assessing whether the patient is stable. Airway management should be ensured in patients presenting with respiratory distress and patients who are dyspneic. Supplemental O2 treatment should also be administered. Remember that immediate tube thoracostomy should be done for patients who require mechanical ventilation. The type of pneumothorax needs to be identified and managed accordingly. Patients with primary spontaneous pneumothorax are usually stable. If the pneumothorax is small, as in less than 2 centimeters, only observation is required, as it usually resolves spontaneously within 10 days. After that, follow-up is needed with the chest x-ray. If there is a large pneumothorax or the patient is symptomatic, supplemental O2 should be administered and a chest tube should be placed. Conservative treatment with observation and follow-up with imaging is suggested in patients with a large pneumothorax if they're asymptomatic. Secondary spontaneous pneumothorax is managed with observation if the pneumothorax is small and if the patient is stable and asymptomatic. Chest tube could be done in patients who are unstable and symptomatic. Patients with open pneumothorax need to be assessed for hemodynamic stability. If bleeding is present due to trauma, then bleeding should be controlled. In addition, cardiothoracic surgery should be consulted. Lastly, a dressing should be used to occlude the opening, followed by thoracostomy for decompensation. The safe triangle describes the anatomically safe place for chest tube insertion and is bordered by the axilla superiorly, pectoralis major medially, and the latissimus dorsi laterally. Chest tubes are placed in the 4th and 5th intercostal space between the anterior and mid-axillary line. After chest tube placement, imaging must be done to confirm the correct positioning of the chest tube. A tension pneumothorax is considered a medical emergency. It's treated with emergent needle thoracostomy followed by chest tube placement. In needle thoracostomy, the needle is inserted in the 2nd intercostal midclavicular line. Remember that a chest x-ray is always required after chest tube placement to ensure correct positioning. In the case of bilateral pneumothorax or in unstable patients, chest tube placement should be directly performed for emergent chest decompression. All right, let's wrap up with a final question. A 23-year-old man is brought to the emergency department after sustaining injuries to his chest during a high-speed motor vehicle accident. On the way to the hospital, he complained of chest pain and dyspnea. A few moments later, on physical examination, he is hypotensive and unresponsive. Pulse oximetry shows an oxygen saturation of 89%. Examination of the lungs reveals decreased breath sounds and hyporesonance on percussion on the right. He also has distended neck veins. What is the best next step in management? All right, so this patient is presenting with hemodynamic instability, most likely due to a tension pneumothorax, and needs needle thoracostomy. This patient most likely sustained an injury to his lungs during the accident. Physical exam findings of decreased breath sounds and hyperresonance on percussion support the diagnosis of pneumothorax. His low oxygen saturation, along with his distended neck veins, should raise suspicion for tension pneumothorax, and immediate decompression is needed and should not be delayed by imaging. So again, the answer to the question is needle thoracostomy. And that concludes this section.